Hello friends, this is Dr. Banerjee, consultant endocrinologist from Kolkata. Today I'll be discussing an interesting, fascinating case of diabetes with the aim of highlighting the role of empagliflozin and nilagiptin combination that has been a powerful addition to the existing therapeutic strategies for treatment of diabetes. So Mr. Kamal, who is a college professor, 54-year-old male with type 2 diabetes since 4 years, during routine checkup, he complained of generalized weakness. He was hospitalized for acute coronary syndrome 1 year ago and went through percutaneous stenting. And his father had a myocardial infarction and he underwent a bypass surgery as well 5 years ago. Now, currently the patient has a body mass index of 29.7, body weight is 71 kg. His blood pressure is 146 by 86 in clinic. His HbA1c levels is high, 8.4%. LDL cholesterol is 75. eGFR is around 50. Urine ACR is 290. And echo showing mildly dilated LA and RA. That is the atriums. And currently her medication include metformin 1 gram twice daily, glimepiride 4 milligram once daily, losartan 50 milligram, atorvastatin 40 milligram, amlodipine 5 milligram, clothalidone 15, and metoprolol XR 50 milligram daily, and aspirin 75 milligram. Now he has a sedentary lifestyle as well and is trying to avoid weight gain and is exercises a few times a week. He is also frustrated that his weight is unchanged. Now he reports occasional hypoglycemic events as well. So currently there are a few important challenges in this patient. First of all, he has uncontrolled hyperglycemia as evident by HbA1c of 8.4%. He is obese, BMI is 29.7. He has hypertension, which is not optimally controlled since his systolic blood pressure is somewhat little bit high. One blood pressure is 144 systolic blood pressure. And he has a history of previous myocardial infarction that puts her in the very high ASABT risk category as per ESA guidelines. And coming to the CKD, the kidney disease stage, he has chronic kidney disease stage 3 and microalbuminuria as well. And his eGFR is currently 50. So the risk status of this patient is quite high. He is a young patient with multi-organ target damage with a prior acute coronary event and very high risk. He belongs to a very high risk of ASABT category. And he has a issue with weight as well. And in this case, the HbA1c level needs to be individualized in view of the previous event. Now, we all know that the type 2 diabetes is a complex disease which caused by the chronic hyperglycemia, which gradually increases over time. And type 2 diabetes is associated with other CV risk factor, cardiovascular risk factors as well. And all these risk factors basically accelerate the atherothrombosis that results in the coronary heart disease, stroke, and peripheral artery disease. And a better management during the last 2 decades actually allowed the reducing the incidence of CV complications, yet the residual risk remains really high. And CKD also remains a major concern, and heart failure particularly is a complication of major interest. And in 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management actually began with the EMPA-REG outcome study, which clearly demonstrated the significant benefits of empagliflozin on risk of heart failure, which reduces the risk of heart failure by 35%. And among participants with baseline history of heart failure, empagliflozin was associated with a numerically lower rate of hospitalization due to heart failure and cardiovascular death, with no heterogeneity between the participants with and without baseline heart failure. Among participants who had an initial hospitalization due to heart failure, empagliflozin was associated with a near twofold reduction in the risk of a subsequent CV death or hospitalization due to heart failure. So it's what is possible that the SGLT inhibitors might prevent the development of heart failure in diabetic patients. Positive top-line results of EMPEROR reduced has been recently published in patients with heart failure with reduced ejection fraction, with and without diabetes. And the EMPA-HEART study also demonstrated that empagliflozin could produce early reverse cardiac hemolytic in type 2 diabetes and stable coronary artery disease. And in a sub-analysis study of EMPEREX outcome trial, the empagliflozin was also shown to reduce the new onset and worsening nephropathy by 39% on top of RAS blocker therapy. So in addition to these cardiorenal benefits, metabolic outcomes in terms of weight loss and blood pressure reduction is also well known with this SGLT2 inhibitor therapy. And because of this, SGLT2 inhibitor seem to have a major role to play in type 2 diabetes management, particularly in this patient. Now coming to the another important drug, that is linagliptin. Linagliptin has a unique profile with a primarily non-renal but hepatobiliary route of elimination that requires no dose adjustment in patients with chronic kidney disease. And Carmilla study have already told us that linagliptin reduced the progression of albuminuria by 14%, and thus our patient who is obese, has systolic blood pressure of 146, belongs to a CKD stage 3 and microalbuminuria category along with high ASCVD risk category will definitely benefit significantly from a combination of both these agents. And this combination can offer a suitable component in strategy to achieve the target HbA1c without hypoglycemia and weight gain. And another important fact is that when you give these two drugs together as a combination, there are enough evidence to suggest that there can be a reduction in the incidence of genital infections, which is generally observed with SGLT2 inhibitor monotherapy because of the better glucose control achieved with this combination compared to monotherapy. So that's why additionally it can reduce the daily pill burden in this population and potentially preventing the treatment adherence of patients and optimizing the benefits of treatment of diabetes management. So with this, I conclude my discussion. Thank you.